Welcome to TPMG Health Talk. Join us for valuable insights and practical advice on health topics that matter to you most, delivered by our top medical professionals. At Tidewater Physicians Multi-Specialty Group, we're dedicated to providing high-quality, physician-directed care to the Hampton Roads community. Subscribe now and visit mytpmg.com for more resources. Now let's dive into today's episode. This episode is a special one, a first for TPMG Health Talk. We're bringing you a conversation between two of our top medical providers, Dr. Lisa Coleman, a colorectal surgeon with TPMG General Surgery, and a returning guest on TPMG Health Talk, Dr. Francis Jones, a gastroenterologist at TPMG Gastroenterology in Williamsburg. Dr. Coleman and Dr. Jones bring more than 25 years of combined experience to TPMG. In addition to their clinical expertise, both are proud veterans of the U.S. Armed Forces, and we're honored to recognize their service. It's great to have you both here today. Thank you for joining us.
Thank you for having me. I'm so excited to be here. Thank you.
Thank you for having me, too.
How often are you guys in the same room together?
Not as much as we want to be.
Right.
We want to be in the room together more often. We love collaborating together. We love being able to discuss patients and coordinating care together. It really is. It's a highlight of my professional existence.
Yeah, we both also work at Mary Immaculate Hospital, so we'll see each other on some endoscopy days, and that's a lot of fun to get to just touch base. But more importantly is we have each other's cell phone numbers, and we are able to communicate. So I always tell my patients, hey, if you've got a problem, give me a call. I've got her number. She's got mine. And it's so important for patients because they want to know that their physicians are talking to each other. And we are. If you come to us, we talk to each other.
Absolutely. I completely agree. And that's the benefit that you get from us is that we do talk to each other. We coordinate care. We care about our patients. We want to know what the other person has done, and we communicate regularly.
Well, we got a lot to cover, and let's get to it. Let's be honest. Some symptoms are just awkward to talk about. Stuff like bloating, unexpected bleeding, pain, and incontinence. People tend to brush these off or hope they go away. Eventually, they are big red flags. Dr. Holman, Dr. Jones, what are some of the most common silent symptoms you see people ignoring?
Ooh, that's a good question.
That is a good question because if it's silent, so what are the red flag symptoms that you get? So starting off straight away, you should not have blood coming out of your anus. If you have, and you need to look at your stools. So many people don't look at their stool. And so after you have a bowel movement, go ahead, turn around, take a look at it. Is there blood in the toilet? Has the shape changed? Is it now flat or small like a pencil, and normally it was large? These are some red flag symptoms. Sometimes people bleed from anal fissures or from hemorrhoids, but you don't want to miss a more concerning cause like colon cancer. Same with that change in the shape. Sometimes that shape is just because your stools are softer from what you ate, and now it's being pressed through the anus, and the anus changes the shape, like piping a cake. But sometimes it could be from a rectal mass, and so you want to make sure that that's not the problem. You have some other red flag symptoms.
I mean, beyond red flags, I think some of the things that I see, and I'm sure that you see the same thing, and I would actually encourage patients to do, but they are very uncomfortable or they're timid or they're apologetic for it. But actually taking photos speaks 1,000 words. It's hard for someone to describe to me what they're seeing in the toilet. And so people are apologetic. Oh, I'm sorry, you probably don't want to see this, but I've got this photo. Actually, I love the photos. It might sound weird, but it's extremely helpful. I know Dr. Jones is seeing the same thing, but it can tell us so much. And it's not embarrassing for us. We see it all the time. It's actually very helpful. One of the things that I do when I see a patient that Dr. Jones has sent to me is I go back and I look at her pictures. What did she see? What did she write? I want to see what she saw. I want to understand what's going on. And so if there's something you're seeing at home, capturing that with a photo, either in the toilet. Some people are actually able to take pictures of what's going on around their anus, what they're seeing, because that might not be the way you present when you're in my office. Just like everybody says, well, the problem went away when I came to see you. Well, what was going on at that time? Take that photo. Don't be embarrassed. It's going to be helpful. I see it all the time. Help yourself. Help me take that photo and bring it in.
That is a really, really great point, because a lot of times I end up giving patients that homework because they come in and they said, something's coming out of my anus and I think I have rectal prolapse. Well, that's really rare. So take a picture. And sure enough, I had a patient take a picture and she actually had rectal prolapse. So I sent her to Dr. Coleman to get it fixed. But sometimes it's an internal hemorrhoid, sometimes it's an external hemorrhoid, but the picture is super important. Good point.
The other thing I would say about the pictures is sometimes I actually get patients to me somehow that haven't yet seen Dr. Jones. They have not yet seen a gastroenterologist to do the evaluation and the thorough workup that a gastroenterologist does. So if you show me a picture that has blood, but it also has a lot of mucus, it has got tissue in it, it's got something that triggers me to say, this might be inflammatory bowel disease, this might be Crohn's disease. You need to get a thorough workup from a gastroenterologist to get those things looked at and taken care of. And then through that photo, I can refer to Dr. Jones so that she can work up inflammatory bowel disease and make sure that you're getting what you need.
I really do appreciate how intentional you both are about communicating and looping each other in when a patient's care crosses your specialty. That type of teamwork makes such a difference, and we value that here at TPMG. Now, are there ways you're there for each other? Like, do you swap cheesy puns?
Oh, yeah. We get to the bottom of it.
It is always. It's
right.
like never-ending goodness here. It really is.
That's right.
I'm always like, this is the bottom line.
Yeah.
Right? The bottom line.
I'm behind you all the way.
Well, I love it. Dr. Jones, Dr. Coleman, we know that as specialists, you both often work together. It's been such a treat getting a firsthand look at that collaboration here on the podcast. But for many patients, it's not always so clear-cut. For those who might be facing challenges finding the right specialist, how does the referral process work at TPMG? Do patients need a referral, or can they come to you directly? And who should patients see first, a gastroenterologist or a colorectal surgeon?
Yeah, that's a good question. My office specifically is a referral-based office. I recognize that many people have insurance that do not need a referral. However, I do prefer a referral because then I get information about what medications they're on, their labs, from their provider. So I am a referral-based office. How about you?
I do believe that I get a lot of referrals both from the primary care providers as well as from gastroenterologists and from Dr. Jones. I do see that there are a lot of people actually that seek me out individually. And I think that both Dr. Jones and myself, being female, have a lot of females that will circumvent normal referral patterns because they really want a female taking care of them. That doesn't mean we don't take care of men. We take care of plenty of men. But there are specifically some patients that do seek us out individually and will self-refer. I think that's reasonable. I think it's appropriate, and we want to see those patients. So we kind of get all comers, I think.
Well, when someone ignores signs, when someone goes months or even years without seeing a specialist, what kind of problems can be caused down the line?
I think you want to pay attention to your body. But the problem is that people are scared. They're scared, they're embarrassed, they feel shameful. There's something that causes them to not bring these issues forward. And sometimes they know. Sometimes they know that there's something wrong and they don't want to know, or they're worried that it's too far gone, whatever it is. I think that it's important to bring these problems forward because, yes, we get presented with advanced disease.
Yes, we do.
Yeah.
And that is sad because don't be the ostrich to put your head in the sand and ignore your symptoms, because you may not want to know, but the quicker we know, the sooner we can get a treatment plan, get aggressive, and medicine has made so many advances that even with cancer, people are being cured or, if not cured, living longer with the medications that we have available. I can tell you one gentleman, abdominal pain, years of abdominal pain. Scoped him, he had a severe sigmoid stricture from diverticular disease. I sent him to Dr. Coleman. She, with her, we got to talk about her technique. This is
Yes.
why I use Dr. Coleman, because she has laparoscopically, minimally, I'm going to let her talk about it. It's just so hot. So this is why I refer people to her. And so he went to her, and she took out that portion, put him back together. He came to follow up to me, and he was in tears. He's like, I didn't know I could feel this good. I didn't know how bad I felt. It's awesome.
Yeah, no, I love to hear that kind of feedback.
Yeah.
You know what I mean? You're hearing them after the fact. And
Yeah.
I usually talk to people and I say, after surgery, I say, can you already start to feel that the infection's gone? Like, are you starting to feel that you had been low-grade sick for a long time and people are already in the hospital, already like, yeah, I can actually feel a difference. I feel pain, but it's different. I feel more energy already. So that is really cool to hear back. I would say, and I know Dr. Jones says the same thing, that the most common symptom of colon cancer is no symptom at all.
That's right.
And that's the most critical thing, is no symptom at all. And that's the reason why we both recommend colonoscopies. Right. And I tell my patients, by the time you have symptoms, by the time you're having bleeding, by the time you're having blockage, by the time you're having abdominal pain, because everyone comes in and says, I feel fine. I don't need a colonoscopy. I feel fine. That's not the issue, because by the time you don't feel fine, that's beyond maybe what I can fix surgically. So you want to get in to Dr. Jones before you have problems, before you have symptoms. Get those screenings done, because by the time you're having symptoms, it might be too late for me to really be able to do something surgically about it. So get in to see your screening with Dr. Jones early, before you have symptoms, so that both of us together can do something about it and make a change that's effective and save your life.
And we talked about this in the last episode, and how screenings, they're lowering the age. And if that doesn't say, get your screenings, I don't know what does.
Yeah, the age is lowered. It's 45. Now, if you have a family history, that might change. You need to give us a call or talk to your primary care provider. Maybe it's even earlier for you if you have a family history. But the age for everyone now is 45. And that's because, like Dr. Coleman said, it grows silently until it's kind of too late. The other thing is, people say, I don't have a family history. Well, yeah, 75% of people with colon cancer don't have a family history.
Right.
If you only screen the people that have family history, you only pick 25% of the people. So get screened.
Dr. Coleman, I'd love to circle back to that minimally invasive robot Dr. Jones mentioned earlier. What was it used for again?
Colon resection. So first of all, she is a board-certified colorectal surgeon, which means she's done advanced study in the colon, which is another reason why I refer to her. She's competent and she's board-certified. She has these minimally invasive tests. Tell them about it. And the robot.
No, I just wanted to let you keep talking about me.
Yeah.
I feel like I want to hear more more things about myself. But,
because she's able to go in and, she's not opening
you don't really
up.
have to keep talking about me.
She has
I appreciate
small
it.
little incisions, these little port sites, so you heal up faster. You're not leaving there with a bag full of narcotics. People don't want to be on narcotics. It's addicting. Everyone knows. But her techniques, what do you send them out with ibuprofen? That's
actually not so far from the truth. I do what's called the ERAS protocol, which is an advanced recovery after surgery. And what we focus on is optimization of the patient before the surgery, so that you go in so optimized that we're already moving towards success. And then after the surgery, we're minimizing narcotics with my small incisions that we do with either laparoscopic or robotic surgery. Our incisions are so small, you recover, you're up to functioning much faster. Now, I tell all my patients, you're going to want to get up and jump up like within days or just a week after surgery. But I tell them and I remind them, you're going to want to jump up. You're going to feel good, but you're still doing a tremendous amount of healing on the inside. There was a lot of surgery that went on the inside that you don't see with those tiny surgeries on the outside. So just remember, take some time and recover. But yeah, we do enhanced recovery after surgery. And that involves, even before surgery, nutrition drinks. It involves giving pain medicines to stop the pain medicine process before it even starts. We're doing that with non-opioids. After surgery, we're doing things like multimodal pain management to decrease narcotics. And I would say of my elective surgeries, 75% of them go home after a colon resection, after having part of their colon removed. 75% of them are going home without any narcotics at all. And they're doing fine. They're doing fine.
They're doing great.
Has that been a big movement?
Absolutely. Absolutely. Narcotics and the prescribing for narcotics, it just got out of hand in this country.
And there's a lot of complications.
Yeah, there's
I mean,
a lot
it's
of
not just
complications.
it's not just addiction. It also has to do with your bowel function and the fact that your bowels shut down with the use of narcotics. And what we're trying to do is promote bowel function. We're trying to get you back up and functioning, and narcotics can actually be against that type of...
What's interesting is chronic narcotic use can actually increase abdominal pain.
Correct.
So I have
constipation.
And constipation. So I have
All the things that we're trying to avoid.
Right. Yes, exactly. So by using multimodal techniques and multiple different types of medications that act on pain in different ways, we're able to avoid the use of narcotics, which avoids a lot of different problems with the opioid crisis that we have here in America now.
Well, thank you for touching on that.
Yeah, I would say that both Dr. Jones and I don't have a problem talking. If there's anything you can critique us on, it wouldn't be that we're silent people. I think that's actually this is the other thing I would say about that are similarities for Dr. Jones and myself. And I will consistently hear this from patients who, by the way, when they come to me, they love Dr. Jones. And I'm like, yeah, I love Dr. Jones too. And they're like, no, we love Dr. Jones. I said, I know.
And they love Dr. Coleman.
Yeah.
After they meet Dr. Coleman, they're like, oh my gosh, she's you. I'm like, yes.
And
our patients self-select to us.
I think that's true. What I will say that we're similar in is that we both have a lot of conversations with our patients. We both spend time having discussions with our patients about the risks of things, the benefits of things, the alternatives, about different medications, about treatment plans. We want the patient to understand about their disease process if they have one. We want them to understand how to help themselves. And if they're a part of their own treatment plan, they're going to have more success. And I know that I spend a lot of time talking to patients. I know Dr. Jones spends a tremendous amount of time talking to patients, explaining things to patients, making sure that patients understand what we're doing, what they have, what they need to do so that they have success in the future. It's critical. And I know that we both focus on that and that it is something that we think is both important.
Absolutely. Absolutely. I do give them a lot of education, and as does Dr. Coleman. The other thing that makes us very similar is our background from the military. So when our background in the military gives us this unique team approach. We're not coming from an executive, protect my job type of thing. We're coming from a mission-oriented background where we work as a team to achieve a goal. And that comes as part of our leadership style. So you see that in our practice and you see that in our clinic where they're like, wow, this is a well-oiled machine. Yeah, it is. Yeah, it is. Because we're former military leaders. We bring that team, we bring that camaraderie, we promote that. And that translates into great patient care and patient experience.
I completely agree. The other thing I'd add to that is we have a lot of patients that are in the military family. They're either spouses of military, they're active duty. I see a lot of active duty soldiers. I know that Dr. Jones does as well. I actually know that Dr. Jones has people who were active duty who saw her when she was active duty and have followed her since they got out of the military. They're so dedicated to her. But we see active duty patients, we see retirees, we see veterans, and because we have that military background, we're able to identify with them their unique problems, the unique solutions that they have, and just the system that they've been in. And I think that type of background allows us to provide them better care because we have a better understanding of where they're coming from.
I actually joined the military when I was 17 years old.
Oh my goodness.
My father had to sign the paperwork.
Really?
You wanted to join the military?
Well, I was a headstrong, motivated person.
I don't know where. That just doesn't make any sense. But okay, go ahead.
It doesn't make any sense, right?
Yeah.
So I was got a scholarship to play field hockey, and I got in.
I played field hockey too.
Really?
God, we're spirit animals. We are so spirit animals. Both in the military, both played field hockey. I love it. Go ahead.
I love it. So then, I was headstrong, and my father was like, well, yeah, we're talking about college, and he was coming up with some ideas. I'm like, well, no, I'm going to do this and this and this. He's like, I'm paying for college, so we're going to have some discussions with this. And I'm like, oh, no, I'm out of here. So I run off Join the military at 17. My father's Marine retired, so he's laughing the whole time as he's signing the paperwork so that everyone can tell me what to do. Because now I'm the lowest rank.
Oh my God.
I can't go to the bathroom without permission. I can't fold my clothes.
Did you go right into the Air Force?
Right into the Air Force boot camp.
So why did you choose
E1.
Air Force since your father was Marines?
Well, that is the one thing that I did listen to my daddy. He's like, first of all, you're ruining my core. No, I'm just kidding. And they didn't have medical. They're medical service by the Navy.
Navy, yeah.
And he said, if you're going to join the Air Force. They're more of a corporate kind of military.
They're bougie. The Air Force. I was Army, but go ahead.
All right. Well, they're bougie. He's like, you want to sleep in a tent or you want to sleep in a hotel?
Exactly.
I said, all right, Daddy, let's go.
Yeah.
So I joined the Air Force. So I'm glad I listened to him. He's always looking out for me. My parents love me very much. Thank you for everything you've done for me.
Shout out to Dad.
Shout out and mom.
Okay.
So anyway, I joined the military and I always wanted to be a physician. I thought I wanted to be a psychiatrist. I got in there. I became a mental health tech and realized, no, I do not want to be a psychiatrist. But that process was helpful in my own personal growth because when you're talking to people about mental health, when you're talking to them about their problems, you have to learn about your own personality and what makes you tick and why are you responding to this situation as you are. So it helped me grow to be a better person, which makes me a better physician. It also helps me when a patient comes into the office that hasn't done anything that I said.
Yeah.
Okay, so instead of being mad, right, at why they didn't do anything that I said, I actually say, so what were the barriers that prevented you from getting this done? And when I say that, then that opens the door to what's really going on. Maybe their parent died. Maybe they just don't have the money to afford that testing. Maybe they got better and then it came back. But you know what the point is? They came back. So if they're coming back, then they want my help. And they're going to get it. You're getting helped. You're getting helped. You're getting helped. But yeah, so mental health. So I was a mental health tech and that helped me. But I realized that I wasn't scared of blood. And I really liked the doctoring aspect and the other part. So I worked all day in the Air Force and I went to school all night on base. They offered on base classes. So I was a really non-traditional student. And so once I finally applied to medical school, they were like, well, you got the hours down of to be a doctor. And so I was able to get the military scholarship and become a physician. So I can't believe every day I wake up and I'm like, oh my gosh, I'm a board certified gastroenterologist. Let's go.
Let's go.
I know. It's always something interesting, isn't it?
What's your story? Tell me yours.
I get asked almost daily. It's usually when I put people on the table that they go, why did you ever get into this? Whatever made you do this? And it's an interesting question because I, like you, well, not like you. I didn't leave and join the military at 17. I went to college. But when I was getting into medical school and I was thinking about how I was going to pay for it, and both my parents are not military, but my father has a significant respect and believes, that the military is a very honorable mission. And so at that time, I applied for the scholarship with the Army, because we're hardcore and stuff. And I'm kind of hardcore. And so, but no, I went into the Army. I got the scholarship for medical school. The military training is always see one, do one, teach one. Okay, that's the way the military works.
Absolutely.
And the existence of the military is truly to train you to do a job. So what better place to go? The whole mission is to do a job and to do it well and to do it successfully. So whether you're infantry or whether you're SEAL Team 6 or whatever it is, you are trained to do the job that you're supposed to do. So when I was in residency and training for surgery, you are trained to do the job that you do successfully and the best that you can be. So was my experience as I went into surgery. Now, why did I go into colorectal? I tell everybody that while I was doing surgery training, which I did in Honolulu, Hawaii, which was a hardship tour. It was a hardship tour in Hawaii.
Triple R.
I never saw the beach, but while I was in the hospital, you could see the whales jumping out of the water from the hospital windows. But at any rate, while I was there, I really thought I was going to go into trauma. At that point in time, ER was the new TV show on the block. And it was all guts and glory. It was Hollywood. There was a lot of
Clooney. Come on.
Glamorous. It was so glamorous. So, I thought I was going to be a trauma surgeon. I even went to LA County and I did my my rotation there. Oh, yeah. And I remember, we had the trauma there was amazing. And I literally was standing on a gurney where we'd already cut someone's chest open. And this was Hollywood. This is real life.
This is real life.
I'm standing on the gurney while I have my hands in someone's chest, massaging their heart as the rest of them are wheeling us all down to the elevator to bring us to the OR. So they're running down the hallway. Yeah. I'm standing on a bar that allows them to.
Yeah.
Poor. So looking at us like with this face. But I thought that was just so amazing. You know what I mean? Oh my God, this trauma there's so much glory in it. But then there was a world-renowned colorectal surgeon that came to do. We would have lectures all the time. Part of everything was
rotating
medical
lectures.
School and residency. We have lectureships all the time. We have world-renowned people come and give us lectures all the time. Education. I
remember our own
weekly,
Dr. Schiffman.
Monthly. Yeah. Dr. Schiffman came
to.
But
San Antonio, Texas.
Dr. Stan Goldberg, world-renowned colorectal surgeon, would come every year to Hawaii and he would give a lecture. And he gave a lecture one year on what it is to be a colorectal surgeon. And at that time, I think they said that, the percentage of colorectal surgeons was low. And the female colorectal surgeons was about 9%. So it was very, very low. And he said, anybody who wants to talk to me afterwards, I'd be happy to talk to them. And I thought, I'll talk to you. And so I sat for an hour with a world-renowned colorectal surgeon. And he says, well, what's great about this particular specialty is you can do huge operations. You can take out someone's entire colon and rectum. You can operate for colon cancer, for rectal cancer. You do these big surgeries, but then you can also do all this very complex anorectal surgery, very complex but smaller surgeries, and you can do colonoscopies too. So there's 3 real focuses. And actually, I would say there's a 4th focus, which is pelvic floor and fecal incontinence. I would sell that.
Absolutely.
So, but he said, and maybe in different parts of your life, you could do the big surgeries, and then maybe as you get older, you want to do smaller surgeries. And he told me that, if you're a cardiothoracic surgeon, you can't really do part-time cardiothoracic surgery. It's not, you don't want to be the guy who's getting your heart operated on. It's like, yeah, I'm a part-time cardiothoracic surgeon. No. But if you wanted to, let's say you get older, or for women who have kids, if you want to do part-time, you could do colonoscopies. You could still provide a lot of care to patients, and it's not like part-time care. You're just not doing the really big stuff. So I thought, this is kind of cool. So I chose to do it. I went into colorectal surgery. I went to my first big meeting. And this is the thing that I really wanted to share, which is I went to my first big meeting, and all of us are, together having dinner or whatever. And we have 1,000 colorectal surgeons in one spot. And honestly, you can't, what I realized with colorectal surgeons, a lot of people are very serious. You and I are not very serious. We can be serious, but there are a lot of specialties that are very, very rigid. They're much more serious. They're dry. I'm not going to name any names, but when you're a gastroenterologist or colorectal surgeon and you're in people's backsides all the time, you can't be too serious about yourself.
Right.
You can't take yourself too seriously.
We're talking about poop all day.
I know, you can't. So I was with all these people, and I'm like, oh my God, these are my people. Everybody is hilarious. Everybody is down to earth. Everybody doesn't take themselves too seriously. And I feel that the same way about you. We can talk about anything. We're excellent at what we do, but we also can help people. The bottom line, right? Is that we can help people feel comfortable about talking about things that are really awkward, that are not talked about, that might feel shameful or might feel embarrassing. And what we need to do is make people feel comfortable about talking about those things that we'd never talk about with anybody else, even their spouses. They won't talk about it. And so I was like, these are my people, and I've never regretted it. I've never turned back. I love what I do. I love what you do. I mean, I think that it takes maybe a special person
it does.
to talk about poop all day.
I agree. I totally agree.
That's what we do.
If you look at it's kind of funny. If you look at different specialties, there's a kind of personality that self-selects to each of them, and GI is known for their humor as well as colorectal surgery. Now, with that being said, I've seen Dr. Coleman and obviously myself too. Sometimes people come in and they're very nervous, and you have to know when to tone it down and when to say you slept at a Holiday Inn Express last night.
Exactly.
Right?
Yeah, exactly. I agree.
Well, what motivates you both day after day to do this work and care for the patients the way you do?
What motivates you?
Well, I tell you what motivates me. I just enjoy medicine. I enjoy GI. I enjoy figuring things out, the diagnostic dilemma, hearing the story to get to the end.
Yeah.
And then when I'm able...
It's a puzzle, right?
It's
a puzzle you got to
It's
solve.
a puzzle.
Yeah.
So what about this? What about that? What about these symptoms? And then finally piecing it all together. And then when I'm able... So when I'm teaching my physician assistant or my nurse practitioner, I'm like, okay, we start off with symptom base. A person comes in with symptoms. And then we do this workup and we reach a diagnosis. And so now you got to change your chart to the diagnosis. And now we dive down into the diagnosis. So when I have someone with eosinophilic esophagitis, they come in with difficulty with swallowing. And then we go through that workup and I diagnose them with eosinophilic esophagitis. Now we can go to treatment. And when I get to put people in remission and make them feel better, and then they forget who I am, I love it. I love it. I was like,
Aw.
we're on this
Who could
journey.
forget you?
Well, they don't. Hopefully. But when inflammatory bowel disease, that's a chronic lifelong condition. And they're coming so sick. And I'm like, we're going to see each other a lot for a while, okay, until we get you in remission. But I'm going to work, and we're going to get you there. And when we do, then you're going to go 6 months, then you're going to go every year. And then don't forget who I am, okay? Remember, I'm the lady at the end of the street, okay?
That solved your problem.
Yeah.
No, I think, too, I completely agree with everything Dr. Jones said. And I think that the puzzle and the diagnostic, the challenge is definitely something that draws us. The other thing that draws me is just the connection. I mean, there's so much wrong with medicine today. There's so much with the system. There's so many places where the patient gets lost. There are so many things where this system gets emphasized, the patient gets minimized. And I think that what I truly enjoy day to day is the connection with my patients. And I think that you do too. That's why you're saying, don't forget about me.
Yeah.
And I think that our patients come back year after year, and it could be, 5 years later, and I'll remember people. And I don't know why I remember people, but I really do, because there is that connection. And I feel like there's been, an intimacy that is valued by both of us, both the patient and the physician, Dr. Jones and myself. And that connection is what drives me to keep going. And
yeah,
there's nothing better.
And that connection brings us more patients, because then, I'll have someone, oh, did you treat so-and-so? They told me about you. And I'm like, HIPAA, but thanks for coming in.
I think that one of the things actually that I think both you and I have is that we have patients that actually want to tell their stories, right? So like one of these times we can discuss and have a patient come in. I mean, I have patients that want to tell their fecal incontinence story. I mean, who really wants to talk about that? But I've had patients that have had such life-changing results that they want to shout from the rooftops to other people to let them know that there are things that can be done for it. And I think that speaks 1,000 words. If you've got a patient that wants to share their story, their personal, their private, their HIPAA stories with other people, it's because they've had success with one of us, and they want other people to feel the same success and have a better, improved quality of life. And that I really think there's nothing better than that.
Yes, we love hearing patient testimonials here at TPMG, and I encourage anyone listening to take a moment to let your provider know you appreciate them. It really goes a long way. And for us here at TPMG Health Talk, we appreciate you both for being with us today. I feel like we've only scratched the surface. We didn't even get into things like incontinence, bloating,
constipation,
anal
pain.
This is our plug here. So I think you need to have us back.
Yes.
And I think we need to do a GI, podcast.
Let's talk about like guts and butts. What do you think?
I think we should call it Guts and Butts.
Tell us what you think,
Guts and Butts.
Guts and Butts with Dr. Jones and Dr. Coleman.
Let's go.
Let us know what your questions are.
That's it.
We want to answer your questions.
Or people listen to podcasts, if you want to contact TPMG and say, hey, I want you to talk about this. We'll even take those too.
What do you want to know about?
Yeah, what do you want to know
We'll answer
about?
your questions.
Yeah, we can go symptom-based, and then we can even go disease-based.
I agree.
Yeah.
I'm in. Let's do it.
Let's go.
Let's do it.
Sign us up.
Let's do it. Well, thank you both for
Oh,
your.
you're welcome.
Oh my God, it's been one of my favorites.
This has
if
been
not,
my favorite.
we're definitely having you both back.
Thank you for having us.
Thank you for listening. Be sure to subscribe to TPMG Health Talk and visit mytpmg.com.
Hit that subscribe button.
Yes,
Hit that and
subscribe, learn more.
Like us, subscribe to us.
That's right.
If you want more, let's
If
do
you want
it.
more, call her.
Hit subscribe, like.
And don't ignore the symptoms.
Don't ignore.
Don't
ignore.
No ostrich.
All right, ladies, how about a quick take care for our listeners?
Take care.
The information shared on today's podcast is not intended to be medical advice, nor is it meant to replace a professional consultation with a healthcare provider. The opinions expressed in this podcast do not necessarily reflect those of TPMG or its providers and physicians.